meeting will please come to order.
I'm not even going to sit down. I'm not going to bend my knees one more time than I have to.
Counselor Vasquez, would you lead us in prayer?
Dear Heavenly Father, we thank you for this day and all the blessings that you give us every day. We thank you for our citizens that we serve and ask that you keep us mindful of them at all times as we go through these meetings. In Jesus' name, amen.
Shelley, you want to
Ma'am, Mary Baker Shaw,
present?
Mike Dobbins. Here. Gil England.
Honey.
Keith Austin.
Here.
Harley Buzzard. Here. Joe Berg.
Honey.
Sean Crittenden.
Honey.
Frankie Hargis. Present. Wanda Hatfield. Rex Jordan.
Here.
Dick White.
Honey.
Mike Shambaugh.
Here.
E.O. Smith.
Here.
Janice Taylor. Here. Victoria Vasquez.
Honey.
David Walkenstick.
Honey.
Brian Warner.
Honey.
We have a quorum.
Thank you. Has everybody had a chance to read the minutes of our last meeting?
Motion.
Motion made to accept them as written. All those in favor say aye. Aye. Any opposed? Same sign. Okay, our first report from the Claremore Service Unit is Kathy Smith.
Hey, Kathy.
Hi, Kathy.
Filling in for George today, and he sent his report and didn't have anything special for me to report on or say, so I can answer any questions or take anything back to him for him to answer.
Anybody with any questions? Yes, Counselor Austin.
Really a public acknowledgement and thanks to George. George has assisted with making sure that the day after tomorrow, a dear lady by the first name of Mamie, who will be 104 years old,
Oh,
who lives at the Claremore Veterans Home,
yes.
gets exactly what she wanted for her birthday.
Yes.
She wanted a stomp dance. And George has helped arrange for that to happen at the Claremore Veterans Home.
Aw.
And that's definitely going above and beyond.
That is
Thank you, George.
awesome. Wonderful. I will pass
She's
that
full
along.
blood, she's full blood Osage and 104 years old.
Wow.
Retired Army nurse from World War II.
Oh, wow.
Wonderful.
Great.
Any other
I got a
counsel-
letter from her family today thanking us for that,
Oh,
thanking
that's
us
really
for our
special.
efforts.
Any other questions? I have a couple.
Yes, ma'am.
I'd like to ask, I see where you're all recruiting a hospitalist.
Yes.
How many beds will that hospitalist be responsible for?
We are accredited for 44 beds. And that
Okay.
includes our OB unit and ICU.
Okay, and then also, I wanted to ask about Blue Cross and Blue Shield. You all recently did an insure yourself, I suppose, with Blue Cross and Blue Shield. Can you tell us how that went and what the purpose was?
Well, I can't speak to that, but I will take that back and maybe George can get that information to you or bring it back next time. Yeah.
And then I had one other question. I see where your orthopedic patients, are now being sent to an ortho group in Oklahoma City, just as I'm aware that Hastings is doing the same thing, or Cherokee Nation. I was wondering, they're looking to contracting a group in Tulsa also. Would you know if that's in conjunction with Cherokee Nation?
I
Or is
don't,
it
I
private?
don't know that, but I'll find that out also.
Okay. I really would like to see us move our orthopedic patients
Absolutely.
into Tulsa, because I think the drive, when you have an orthopedic problem, such as a broken leg or something, it'd be very painful to make that extra longer trip.
Absolutely.
And I think that's
Yeah.
a really good idea.
Yes.
Anybody else with any questions for Kathy? Kathy, thank you for joining us today.
Thank you, I appreciate it. And I will pass that along to you.
Oh, I'm sorry. Dr. Graham, would you please join us?
Everything fine. I'll wait till you call me up here.
Well, I'll get you up here eventually.
Good afternoon, everyone. I'm going to talk about just a couple of quick issues and then have someone join me up here that we were requested to have talk a little bit, and then we'll get into any questions y'all might have about our report. We got the recruitment report sent out to you a little bit earlier this month, and tried to get it into you before the weekend so that you'd have a chance to look at it. Two new hires I wanted to mention. We're getting a Cherokee citizen who's coming back to work for us, who went through her residency here. Dr. Amanda Big Horse Dominic is coming back to join us as the medical director at Veneta. She's originally from Pryor. She graduated from NSU and completed her medical education at OSU. Did her residency in family medicine here in Tahlequah. Ended up as chief family medicine resident. Remained with us after her residency. Left last year to work for the Osage, but now she's returning to us, so we're very excited about that. She said this is where her heart is, and we're very happy to have her back. Also, another hire at our J facility, Dr. Daniel Nichol, the new full-time provider there. He starts on April the 2nd. He's an experienced physician that comes to us from Integris Grove Family Medicine. He has had a successful career in family and obstetrics with St. Francis in Tulsa. He was chief of staff at Southcrest Medical Center and held academic positions as faculty instructor with In His Image Family Practice Residency, a clinical assistant professor of family medicine with OSU, College of Osteopathic Medicine, and OU Health Sciences Center, College of Medicine. He began in family practice, also doing it at Truman Medical Center East in Kansas City. So we're very excited to have him back. Dr. Nichol, Nicoll. He and his wife reside just outside of Jay, and he's very anxious to see and hopes that many of his Cherokee patients will follow him over from Grove. I also want to add, Counselor Buzzard, that as much as we can ever commit to anything, we have two providers, two full-time physicians who have signed those letters of commitment. And after their residencies this summer have told us that they would like to come on board in the spring at J. So at that point we'll have our physician staff complete. So we've been working very hard on some of the outlying clinics to get those completed before we start doing anything here. Councilor Lay, still looking hard at Oshaleta. We have some leads, but we don't have one coming there just yet. So. I also wanted to let everyone know that the provider survey is complete now. It's been closed. We had a 91% response rate. Very, very high. Never seen one quite that high before in many of the survey work that we've done. So we're very anxious to get those results. It's probably about 70% complete. I talked with our staff today. There were a lot of comments, so they're working on, categorizing those, and I think it'll be very interesting, once we get a chance to see it, and I'm looking forward to that. You have been told about this before, but I don't think we'll meet again before this occurs, so I wanted to mention it to you one more time. For those of you that are able on Saturday night, April the 7th, at the Hard Rock Hotel and Casino Sky Room is Our Docs Rock. It's the annual appreciation event we have for our physicians, dentists, APRNs, PAs, and we have a sit-down dinner, award ceremony, and the band, and you all are invited if you're available that evening. So we had been asked some questions about optometry, eye care, and we've asked Dr. Nate Lighthizer, who's the Assistant Dean of Clinical Care, to join us today. While he's joining us, I'll briefly tell you the way things are set up. The Cherokee Nation contracts with Northeastern State University, Oklahoma College of Optometry to provide the optometry staff and manage those for us. We provide the clerks, the optometric, para-optometric technicians. Those are on our staff and payroll. And this has been going this way for many years. It's been a good collaboration between the university and the Cherokee Nation, and I'm going to let him talk now, and if you have any questions for him about the eye care program, if he and I can't answer them, we'll find you the answer. So go ahead, Dr. Lighthizer.
Thank you, Dr. Grimm. Thank you to the council for inviting me. I'm, again, Nate Lighthizer, Assistant Dean of Clinics at the College of Optometry, head of all the clinical care there. So I'm here to answer any questions that you have about eye care, optometry, ophthalmology in general. So I'll open it up to the floor.
Councilman.
I think I had said something about it, and I don't know if the question was, I think back then, is it was taking us at the J Clinic. They had 2 patients call me and said they couldn't get an appointment until August. Felt like that was a little bit longer waiting time that I would want to wait, but I don't know how that's set up. Do you handle the scheduling through NSU, or does Cherokee Nation handle the scheduling, or how does that work?
Sure.
But it just seemed like a long time for a patient to wait.
So every clinic handles their own scheduling. You know, the J staff and doctors handle the scheduling there, and the same as all the other clinics. It depends on what their symptom is. If somebody calls in with an acute problem, they should be seen that day. We handle what we call walk-ins and things like that. If they do call and schedule it, what we call a general exam, they may be scheduled in whenever their next available general exam is, and it may be in August, it may be sooner, it may be later, depending on the clinic. So a wait time of approximately 5 to 6 months is on the longer end. Again, some clinics are shorter, some clinics are longer. One of the reasons, potentially, the demand for eye care services does exceed the supply of staff and doctors in the clinics.
Okay, and the reason I bring it up is people that call me, they are fully insured. They want to use our clinic. We're hurting for money here for health services. It just seems like we need to do more. That's all I'm saying.
I agree with you.
Thank you.
Could you please explain to us about how the rotations work through our Cherokee Nation clinics, and versus how many students you have available to assist us?
Sure. We have 28 students in each class. It's 4 years of optometry school, so we have first, second, third, and fourth years. And they enter clinic in their second year, and they start rotating through all of the clinics. We have 8 what we call REPs, the Rural Eye Program, and that would be your Jace, Salinas, Stillwell, Sallisaw, Oshaleta, etc., those 8 clinics. They start rotating through those clinics in their third year. And they will see patients along with the attending doctor in their third year and their fourth year. So on any given day of our 28 students, we may send 10 students out there, we may send 15. The number varies based on whether they have class that day, whether they have clinic. But on any given day, we have 10 to 15 students that are out in the clinics, in the what we call the REPs, seeing patients along with the doctors.
I would point out, too, that those clinics are fully staffed with full-time doctors, and these are just supplemental, staff coming in to assist and help see more patients. So.
And they, if I may add, they provide a valuable service, because if you've got 3 students, they serve as helping assistants, technicians, however you'd like to call them. You may have one of those in 3 different rooms, and the attending doctor can go from room to room, and you've got 3 patients being seen at any one time, versus if there were no students that day, then it's just the doctor seeing those patients and has to do every part of the exam. So it certainly does increase efficiency when we have them there.
Could you share with me, are patients given glasses should they need them? Could you explain that policy to us? Sure.
We have the eyeglasses program through Field Tax, which we utilize for many of our patients. There are certain guidelines or qualifications to be able to qualify to get your eyeglasses through the Field Tax program. Those were adopted in 2012, or they should say they came about in their current form in 2012. So if you're under the age of 18, if you're over the age of 55, diabetic, or a full-time student, you qualify for services. You qualify for eyeglasses through the eyeglasses program. Those are the 4 qualifications. There is a 5th based on income as well. So those would be the 5 qualifications. Again, it's age, diabetes, and diagnosis of diabetes, or if they qualify via income as well.
So, if I understand this correctly, these glasses are provided in-house, correctly? Am I correct on that?
They go to the dispensary and they will choose the pair of glasses that they fit, that work for them, and then those are ordered and made off-site.
Okay, so if an at-large, let's say, patient comes in and they happen to be in the area and they come into the clinic and they have their eyes examined and they need glasses and they meet this criteria, they can too get their glasses for free. Is this correct?
As long as they meet the guidelines, they can get their eyeglasses covered through the eyeglasses program.
I'm very glad to hear that. Thank you for clarifying that. Yes, Counselor Dobbins.
Yes, doctor, on average, how many patients does an OD see on a day, just across the clinics on average?
Across the board, generally speaking, it obviously depends on how many exam lanes you have. It depends on the number of staff, technicians, the number of students as well. But if you put a doctor in a clinic with no technicians, no staff, an average OD will see 8 to 12 patients per day, 8 to 10, 8 to 12. Because an average exam takes about 45 minutes to an hour with no assistance during the exam.
In those 45 minutes, in some clinics, the 3rd and 4th year students provide that support.
That's correct.
So if you were charged to make our optometry clinics more productive, would we want to increase the support personnel or more ODs?
I think it'd be, in my opinion, it would be a combination of both. You have to have the support of staff, and we have staff members at the front desk that are answering telephones, checking patients in, checking patients out, running the front desk. We have staff support in the dispensary. You have to have a personnel in there to fit eyeglasses when they're ready to pick their glasses out, and then you have technicians as well. Our students serve that role in many clinics, but an increase in staff, and especially, in my opinion, the most important, probably an increase in ODs across the clinics to help meet that demand that you had referenced.
So is there a specific plan to address these scheduling out 6 to 8 months? Is there a specific plan what we're going to do to maybe shorten that wait?
There is. Dr. Grimm and his team and our team are working on that plan as we speak.
Counselor Crittenden.
There are children given, if they come in needing an exam, are they given the same time frame as anyone else, or do you kind of look at that situation like this student may need it for school?
That certainly meets a higher priority. They're all high priorities. We have a special clinic at NSU that we call Infant Vision Clinic and Vision Therapy Clinic. They're two separate clinics. So if we see a child under the age of 12 to 15, somewhere in there, usually under the age of 18, and they require specific visual services, we'll send them over to Infant Vision Clinic or Vision Therapy Clinic to get that done.
Yeah. Thank you.
So, just so I understand correctly, I'm so sorry. Counselor Lay, you go ahead.
I'll go ahead.
Okay, thank you. If someone needs an appointment to have their eyes examined, their children are going to school next fall, they need to make that appointment now, then, because it's going to be at least 6 months. Is that
Based on the
correct?
certain wait lists at various clinics, we'd encourage them to make that appointment as soon as possible.
And those appointments are made through the Division of Optometry, or is it made through the hospital scheduling?
I believe they call the optometry clinic in each of those various clinics there, whether it's Jay, Muskogee, Salina, wherever, they'll call the optometry clinic in each clinic.
Thank you. Counselor Lay. I'm
Thank you, ma'am. The age limits from 18 to 55, I'm not sure I understood that fully. Can you explain that?
Sure. So anybody under the age of 18, they qualify for the eyeglasses program. Over the age of 55, they qualify. So anybody, again, 18 to 55 is the age range where they don't qualify at that point. If they have a diagnosis of diabetes in that age, they would. Those are the guidelines that were drafted with Cherokee Nation and NSU together before my time, but they were drafted together when the eyeglasses program came about.
And we seem to be limited on hardware, I guess I call it frames, at some clinics. Is that your job or health job, or who takes care of that?
I'd say it's sort of a shared responsibility, and we have a pretty good selection, of frames at all the clinics that I'm aware of. If there's one that we don't have very many, let me know. What we have more of a restriction on, if you will, not necessarily restriction. We try to meet all these, but as Dr. Lighthizer said, the demand for glasses far outstrips the capacity that we have to provide them. And so this is why we've set these criteria. And, you know, if you meet those criteria, then you get them at our expense. If you fall outside of that category and you come in, then, you know, you can get it, but you pay for it. So, but I don't even know if we get very many people in that are outside those categories or not. Do you know?
We do, yeah. We're currently going through a process right now of standardizing our frame selection across all the clinics. You know, we've worked with Cherokee Nation at your request to say, well, we don't want just these certain glasses here, and then patients say, well, I want to get the glasses that I saw at this clinic over at my clinic. We took and looked at all of our top vendors, the frames that sell the most, that are the most popular, that patients seem to like the best, and just said, let's put all those in the clinic so patients get a nice selection of the frames when they go to each of the clinics. So it's very consistent across the board. So we're currently doing that.
Well, I'll get with Dr. Grimm later, but I think if you're willing to travel, you can find a better selection at some of our clinics. Maybe it's the size of the clinic, I don't know.
Well, we are looking at it right now, and if you'll talk to me later about which ones, we can kind of do a comparison. I know there are a lot of frames out there in a lot of the clinics. We've talked about that too, you know, the sort of the volume of choices there are. So.
And it's a continuous process. We are continually looking at different frames to get the best quality at the best possible price point.
Thank you.
Counselor Smith? Counselor Shambaugh, I'm sorry.
Are there circumstances where, is there circumstances where contacts are made available to anybody, or?
That's correct. If somebody desires a contact lens prescription, they are referred over to NSU for our contact lens clinic. Along the lines of infant vision and vision therapy, we have what we call specialty clinics over at NSU, and the contact lens clinic is there, and it stays quite busy over at NSU.
Are those covered in cost?
Say again?
Are the contacts cost, are they covered?
The contacts are not covered. They are not part of the eyeglasses program unless a patient has a medical condition that the glasses will not correct their vision because of their medical condition. Then the contact lenses may be covered by the eyeglasses program.
Speaker Bird?
Yes. Back in the late 90s when we did the motor fuels compact, that's one thing that we put in as a council is not all the criteria, but most of the criteria here. But here's some of the frames that I received there. But I paid $100-something for them. But well worth it. I think you've got a pretty good selection right now at Hastings. I don't know about the other clinics, but Hastings has pretty good selection. That's back when Dr. Foster, we negotiated that MOA. Is he still there?
Dr. Foster has recently retired full-time.
Wow. How do we rate as optometry school throughout, the area there? Seemed like last time I visited, you had people from all over wanting to get in, and then you had even foreigners were there. I mean, it seemed like it's a pretty prestigious school right now.
Certainly I'm biased, obviously. I did not go to optometry school here. We recently opened up our eligibility to anybody across the nation. When I went to optometry school, it was Oklahoma and the surrounding states, the nearby states. It has now opened up to all states. We are widely regarded, again, I know I'm biased, as the top optometry school in the country in terms of training in the management of eye disease and other conditions.
Wow.
We have a lot of applicants for 28 spots, so it is very, very competitive.
We're number one. We just want to stay number one, I think. How many I don't know, it may be in this report, how many of our tribal members are in that 4 groups that you were talking about? If you don't have it, could you share that with us next time?
In the students?
Yes.
What percentage of our students are
Tribal members.
tribal members? I'll have to get that number
That's
for you.
okay. All right. Thank you very much, Madam Chair.
Yes, any other questions? Yes, Dr.
Out
Dodd?
of those 28, do you have a formula on how many in-state residents you take?
It's an approximation. I do know that number. It's approximately 50-50. It's about 50% of our incoming class is from Oklahoma, and about 50% is outside of Oklahoma. That varies every class, but it's approximately
Are you
ballpark.
held to that? Half your class has to be out of state?
I can find that answer out if we are.
You get out-of-state tuition on those out-of-state students.
They do.
I would add too that it's rare that there is not at some point in time a IHS scholar payback, going through our program that wants to come work for us. Sometimes we've had 2 or 3 at a time, and a lot of times they'll stay on once they get through. So, you know, they won't be a payback anymore, but they continue to stay with us. So there are a lot of Indian students that come there. A lot of them want to do their payback at our sites because they've done training there. A lot of them are from around. So we'll get that number to you that you requested, but it's unusual that we might not have any scholars at any given point in time, you know, doing a payback unless they just all happen to be full and, you know, there's no room for them at that point. So
I know you don't know this, Dr. And we currently have 3 fourth-year students that are set to graduate in May that would like to come work for Cherokee Nation as they are IHS Scholar paybacks.
That's wonderful.
Great report.
Any other questions from our council?
Just a comment.
Okay.
I appreciate the partnership that they have with us. I know a lot of our elders utilize that program for the eyeglasses. And I know this council passed a resolution back in 2013 to increase the dividend to 35% to provide eyeglasses. So we appreciate y'all's willingness to partner with us. So it's a win-win for everybody. So we appreciate that.
I agree.
Okay,
Thank
there
you.
being no other questions, Dr. Lighthouse, thank you for taking time from your schedule to come and share this information with us. We're really grateful.
Thank you. If you ever need anything, please let me know.
Thank you so much. Okay, Dr. Graham, would you like to continue?
I'm at your disposal if you guys have any questions you'd like to ask about our report or anything else.
I haven't. Is you going to give anything, or are you going to
Are you
call
go-
Dr. Nolan or Brian up to give a brief report?
Are you going to talk about Baylor or not?
Yeah, unless he's...
Okay.
You want,
No, just a minute. I do have a question. I was noticing on the vacancies at WWH that we have one physician opening in UC. Now, I have a nursing background, and I've never heard of UC. I've heard of cardiac care. Is this urinary care?
urgent care.
Urgent
care.
care. I'm sorry. Okay. Shows you how outdated my nursing degree is. Urgent care. Well, I'm glad you explained that because I was sitting there thinking urinary care or something. Cardiac care. It could be, yeah. Okay. And I know Speaker Byrd has some information that he would like to share.
Yes, okay.
No, I just want to thank you for sending some staff members with us to Baylor University to look at ways of maybe preserving the limbs of our patients. It was called, I don't know what terms they were allowed to use there, but it was saving the limbs of our diabetic patients. And I would like to have Dr. Doug Nolan and Brian Hill come and just give a brief narrative of what that entailed. I want to thank Secretary Hoskins for accompanying us, and we had the chair, Mary Shaw Baker, go. We had Counselor Warner and myself, and these fine gentlemen were able to ask most of the questions from the CEO standpoint and from a medical standpoint. And, you know, very interesting meeting. We're still gathering data, but we'll let them give a little background on what that entailed.
Thank you for joining us.
Thank you, and thanks. I appreciate Speaker Byrd for inviting us to go on this. As everyone is aware, limb salvage is very important to the Cherokee Nation. We have a large burden of diabetes. Because of that, you get decreased blood flow in the limbs, and so if you have an ulcer or a wound on the lower extremities that don't heal, there's always the concern that there'll be an amputation. So we're always looking for further things to improve the care that we provide. What we found at Baylor Scott & White is they're doing a procedure called BMAC, which stands for bone marrow aspirate concentrate. What they actually do is they take the cells out of the iliac crest, that's the large bone in the hip, and inside that bone marrow there's blood that has what's called precursor cells. They will draw that out, they concentrate it, filter it, and then inject it into the tissues of the wound that's not healing. The thought is that by doing this, it encourages not only healing, but it may encourage increased blood flow to the area. It's called angiogenesis, but it's new blood flow that would go into the wound to help healing. The issue is this is not for every patient. It's really more of a when you've exhausted other, other treatment. Like I said, most of the issue is that there's not good blood flow. So it would be issues that we've already performed, possibly placing a stent or a bypass to try and increase blood flow. So it's not for every patient, but it is a possibility that was very interesting because they've had good success there. We have asked, they've been involved in 2 studies, and the outcome that we've been told is that it's been very good for them, but we're wanting to look at the studies for ourselves. Because as we've looked at other resources, their outcomes have not been, I think, as positive as Baylor, Scott, and White's. We want to look at their studies and see how successful it is through the studies, and is it something that we could either replicate or use their resources. You have anything to...
I think the only thing I'd add is that the results of the study so far are intriguing. The meta-analysis still shows kind of mixed results. And we're kind of looking to see how many patients we have through Contract Health and at Hastings that would qualify for this kind of therapy, because basically it's for patients that have undergone endovascular intervention and everything else, and this is the last stop, the last thing before amputating the limb. So it's intriguing, and we'll continue to watch the studies and see what our numbers look like.
That was an exciting opportunity that we got to share with them, and they shared their information with us. I would like to add that Baylor Scott White Clinic has offered to share all their information with us. They have offered to train our staff, including the home health staff that would take to follow up on follow-up visits. They shared that they had a desire to reach out and help a good organization or a good cause, and that they had decided that this was a great fit to work with the Native Americans this year because of our incidents with diabetes and amputations, and that they wanted to share this with us. It would require I don't even think we have to buy the centrifuge, if I understood them correctly, no. But we would have to buy the little kits that the bone marrow would go in, and then the kits that would help treat post-operatively. And they're $39, if I remember that correctly, on the cost. But this is a win-win thing. I mean, it's going to cost us nothing to receive the information. It's going to cost us nothing for the training. And I want you to know that they treated us so kindly and so fairly down there. They actually brought in the president of CEO Baylor. They brought in the chief vascular surgeon. They brought in their chief surgery nurse, Department of Surgery. But, I mean, they brought in everybody. The chief financial officer was there. To give us an opportunity to ask all the questions that we felt we needed to know, to have a better grasp of understanding, to bring this back to Cherokee Nation. And it's very exciting news. And the way it works is they would draw the bone marrow, and then they spin it down, and they take the stem cells. And the stem cells is what they inject. And they've told us, shared with us, that after the first day, they can see progress immediately. And the worst case scenario, of which they showed us pictures of, it had been 6 months, if I'm not mistaken. And this man's going to keep his leg. And he needs to be very thankful that he was in that blind study, and he was on the receiving end of the stem cells. But it's exciting, and this is something that we hope, with the expansion of the new hospital, the new clinic facility and all, that we can possibly bring back this training to our Cherokee citizens. And I thought it was a really awesome time, and I liked lunch too. They gave us a very nice lunch. Anyway, but it was a great day, and I think the Cherokees have a lot to look forward to in the future. And I really appreciate your insight and your sharing the information on that. Any questions of these
Warner,
gentlemen?
You got anything to add?
Oh, I was impressed with you pull it, you spin it, you re-inject it, basically. I mean, it's a little more complicated than that, but I mean, they've got it down. The numbers on, you can look at the cost of what it costs to amputate a limb versus what it costs to do this. I think the cost is worth it. I think what Dr. Nolan and Brian are doing is looking at all that research, because you've got kind of an older set of research. They're doing some stuff now, I think, looking at that, and there could be some factors in there that they see of why they're more successful. I think that's what we kind of got to understand on that, is looking, because some of the other rates weren't as high. They're taking a look there may be some little nugget in there that everybody's missed when you look at the big picture that we kind of find. Just wanted to see if it works within our frame, but I think to me, one of the biggest things was they were really bought in. The Baylor people weren't there to sell anything to us. They were there to share, and that's science in its, best form, is that sharing of that information. So, a great group of folks, and it was kind of, what really struck me was kind of afterwards, after the meeting, when you're meeting with some of those folks that are in on the ground level, they're in the trenches, and when they were really excited that 2 or 3 of the doctors that showed up, I guess they're really renowned in that area, and they were just kind of like, wow, did you see he showed up? They were really excited. So I think that was, and I just, when we went around table and asked them, and there was some things brought up, and one thing that really stood out is I asked them about the cultural sensitivity and the aspect of working with Cherokee folks, and they assured us they've already done that with some other cultures that aren't even Native American and stuff. So they realize what it's like to work with a different group and knowing that patient on another level, and the fact that they were just so willing to help train us, send people down, whatever works, kind of, so I was very impressed. And I'll tell you right now, some of those photos, I like those before and afters are really shocking. The proof's in the pudding a lot of times. Even if it was a last-ditch effort and there was something out there and it was only a certain percentage, I'm in. I would go down there and give it a shot, to save a limb or whatever. Because when you're talking about revasculating, arterial circulation and stuff like that. And there's some things when they're talking about taking the blood to the area and taking it back that they're better at doing. But all in all, it was good. And what we're doing, though, we're not just jumping right in. Rest assured, they're looking at every aspect and seeing if it will work, if it'll fit for us. And I think anything, that's what we do best, is look for our citizens and see if that's helpful. So, very good.
I'd like to say special kudos to Speaker Byrd for arranging all of this through connections that he had. But for us to be the first Native tribe that they had spoken with, I think speaks volumes for us. I wasn't aware that they were going to speak with any others in the very near future at all. Was that discussed?
I don't think so.
I don't think it was discussed at all. But I sure appreciate all our delegation going and attending and being available, making themselves available for something I think this is significant for our Native people. And I appreciate that very much. Thank you all.
Thank you. We appreciate being part of it.
Is there any questions you all would like to ask these fine gentlemen here? Yes, Councilor Vasquez.
Yes. Does that procedure have anything to do with age of the patient? I mean, is there a restricted, like, elder age where you wouldn't do it? Or would it actually work on anyone that's facing that?
Not that I'm aware of.
They didn't give any
They didn't give any
criteria.
ages.
Okay. Thanks.
The main thing I think was that it was more, you've exhausted, we do a lot of the treatment currently, but this would be something that we could possibly add, because we all know amputations are devastating.
Yes.
About how many amputees do we do a year on the average? Is there any numbers?
Currently at Hastings, we do one every 3 to 4 months, so it's not very many. But what we have to look at is our entire population. So Brett Hayes in Contract Health is getting us information on other patients that might not be coming through Hastings, that we want to capture that and see how many there are.
Is this injected as a last stage, or can it be more preventive than what you're talking about?
I'll let Dr. Nolan speak to that, but my understanding is it's the last stage.
Okay. So that's your understanding that
It is more last stage. Now, there are some times that occasionally you may do an amputation of a certain area, say the midfoot, but you're concerned that the blood flow may not go that far. Unfortunately, I think people are aware that once you start an amputation, it's not uncommon that you end up having to go further up. So there's a possibility that you could use it in that area to maybe decrease the amount that was amputated. But it is the last step. That's something that sometimes patients don't understand, is that, if there's decreased blood flow, we want to open that up. You still need to try and get to viable tissue, so there's still the wound care. But these are for those wounds that, despite every best effort, won't heal.
so there had been some success on stopping amputations for a year, 2 years?
Yeah, in some cases, that's exactly right, 'cause that's how this would be used. If you, unfortunately, once you have the wound, if it won't heal, you finally end up with that point that you have to make a decision. You've done all the treatment you can, and the wound still won't heal. So it comes down that you have to consider amputation. So this would be something that if you get the wound to heal, you possibly would not have to amputate.
Okay.
And that's the hope.
So in a sense, it is some preventive stuff too, then. Okay. Thank you. Thank you.
Any other questions? I would like to also see if Secretary Hoskin has any comments. He also was part of our delegation for the whole day.
Well, I can't add much of substance to some medical technology of this magnitude, but I appreciate Speaker Byrd's leadership in arranging the meeting, and it's always good to get out in the field and see what works. Of course, just as important, the work that they're going to do is sort of evaluate whether this can work for the nation. So,
Thank you.
appreciate it, Speaker.
Yes, thank you. Okay, Dr. Graham. Can't get him off the
Thought you might be through with me too.
Okay. Anybody have any questions for the Health Committee to Dr. Graham? Yes.
Just one, Dr. Graham, on the
Yes, sir.
follow-up a little bit. I know we were busy the other day at the building, but on direct studies program, we talked a little bit about it. Because I've got 2 or 3 kids, not kids, but young adults that wants to get into medical fields. So I want to make sure I'm telling them how to go about doing this. Should we refer them to education department or to career services, or just how would we do that?
Both,
Oh,
you know, I
okay.
would say.
Well, that's what I would have done, yeah.
And then the secretary the other day posted, you know, about the IHS scholarships that are out there too. IHS has both pre-professional, so in their undergraduate years, and then once they get into school, into their professional school, whatever that might be. And then we are going to work on the OSU College of Medicine here at Cherokee Nation to see if we can get IHS, and I feel certain we can get our own tribe, you know, to give some level of commitment to it, but perhaps we can get from IHS a commitment for either scholarships or loan repayments if they don't get scholarships, or perhaps both, you know, that would be committed to this school, depending on how many native students went into it in any given year. And we've already been talking to them about that. They seem very open to the idea, I believe, but, you know, the proof will be when we get a first class selected, see how many there are, and if we can get them, you know, IHS scholarships or something from the tribe or somewhere else. But
I had talked to some students about a shadowing program also. I know we did a shadowing program with the pharmacy department last year. We got started a little bit late, so it didn't really work out like the student had wanted, but still, I take it that you're in full support of any shadowing program when we get into the medical field.
we are, and we're trying to look right now at the number of agreements we have with various schools.
Okay.
Because of the requirements of background checks and things like that. That both takes time and a cost to our program as well, and if we can work it out with the individual schools themselves. And we're having our professional staff take a look at how many of those we have currently, how many have we gotten, how many have we recruited students from, you know, on a regular and recurring basis, because over the years that number gets very big of the number of schools that we have affiliation agreements with. And a lot of times because one student, you know, maybe was Cherokee or had family back here, Cherokee or not, wanted to come work here with us, and so we have this agreement that sometimes lives on for years. So we're in the process of reviewing those right now. I'll just tell you that to try to be strategic, you know, with how we do that. But yes, we're supportive of that.
My time. Thank you. Thank you.
You're welcome. Yes, Councilor Kingston.
Do we have any issues as far as contracts negotiated with our new healthcare facility?
With the joint venture clinic, are you talking about, or?
I'm not sure. I just heard we may have, I just want to know if we have any issues with negotiations with a new healthcare facility with contracts.
Not that I'm aware of,
Okay.
but if you hear anything.
Nothing specific, it was pretty broad.
Okay.
So if you don't know anything about it, then there's probably nothing there. So,
I'll look just in case, so.
okay, thank you. Thank you, Chair.
Thank you. Dr. Grimm, I have a couple of questions. Number one, tell me who does the, let me reword that. What procedures are we doing that involves Northeastern Health Systems? Can you give me some examples? That we would have contracts?
You know, to be totally prepared for that, I would think I would have to look that up. I mean, we do have the agreement with, of course, the College of Optometry. And that is probably our biggest one that I'm aware of.
I'm sorry, let me reiterate my question perhaps. We share equipment, okay, go ahead then.
I thought you meant the college. You're talking about Northeastern Health System.
Health systems, yes.
Okay. Well, we have a number of contracts with them then. We send, and you know, we have a joint business between us called Cherokee Health Partners. And that runs, underneath that are a couple of entities. And you know, if you wanted to get into a discussion about that today, I have just the people here to do that. I can tell you a little bit about it, but we have our CEO who helps operate that for us. But under Cherokee Health Partners, just a few statistics for that. We have 48 employees. That entity is jointly owned by us and Northeastern Health System. We are the primary partner, you know, 51-49. Last year there were 21,000 visits and procedures that were performed. And also under that there is a heart center that we are also primary owner of. CHP owns, I need to get out my charts because I just got on that board. You all voted me onto that.
Last meeting, I think. Did you say Heart Center?
I've been to one board meeting so far, so I'm still learning. Say that again?
You said Heart Center, there is a Heart Center.
There's a heart center under that too. And if you'd like, I can have Mr. Wayne Caldwell come up and speak if you'd like. Depends
Okay,
how
we
much.
have time, sure.
Okay. But there are three.
What's this gentleman's name so we'll know?
Mr. Wayne Caldwell.
Caldwell. Okay.
Wayne Caldwell.
Okay.
Thank you all for having me today. I'm glad to be here. So I'll give you just a little brief history, and then you can ask questions in regards to that. So 2004, Cherokee Health Partners came together with Northeastern Health System, or Cherokee Nation and Northeastern Health System, and created Cherokee Health Partners. This started back with Chief Swimmer, and this was we were talking about this with Dr. Grimm the other day, and one of the visions when they were location of the new hospital was partnership and shared services, for funding and different things of that nature. So in 2004, they decided, well, one of the things that we need to look into is imaging. So 2004, they created Cherokee Health Partners. Currently has echocardiograms, which is performed, and also a nuclear stress test. Back in 2015, Cherokee Health Partners decided to buy ownership into Northeastern Oklahoma Heart Center, which is ran and operated at Northeastern Health System as well. Currently, we're looking at talked to Councilor Warner about this a little bit. We're looking at expanding Cherokee Health Partners down into Salisaw to provide echocardiograms as well. We have been very busy. It's only grown over the past, since 2004, and it's lots of things on the horizon.
Since this is a partnership, may I ask where these records are stored and who is responsible for maintaining and reading them?
Yes, these records are stored in Northeastern Health System's electronic health record.
Okay, I'm sorry, we own 51%. Please
Correct.
explain to me why it's stored in your facility instead of ours, your record system instead of ours. I mean, we're getting ready to open a 469,000 square foot facility. Will we not have abilities to store this type of data in our new facility, Dr. Grimm?
Well, right now, a lot of the services that are provided down there are stored down there on their electronic health record. Any services that are provided by employees from CHP that are provided on our patients in our clinic are stored on our electronic health record. So those kind of records are stored wherever the care is delivered, correct?
Correct.
So board records, if you're talking about, minutes and those sort of things, bylaws, all of that, then, those are, it's a shared entity. Both entities have, copies of all those records and things like that, if I'm understanding your question correctly.
Yeah. Mr. Caldwell, could you please tell me what type of cost do we share with you in storing these records?
So I'm a Cherokee Nation employee, and I just manage the practice there. There is currently not a cost that I'm aware of storing that. That's just a use of electronic health record. There's no indirect costs that we receive on a monthly basis to utilize that health record.
I guess I'm wanting to know, will we ever have an off-site record base for data storage in conjunction with the new health facility? I want to know if that hospital, God forbid, a storm came down and wiped it out, where are our records? Where are they being stored and who's maintaining them?
We currently have backup of all of our records that are off-site.
It is off-site.
Mm-hmm.
And who maintains that off-site base station?
I'm going to make sure I'm saying the right thing, but Cerner, who is our electronic health record vendor, stores those for us. Is that correct, Dr. Stalkup?
So the Cerner medical records are stored in the cloud, so to speak. There's a Tier 4 data storage center up in Kansas City that stores those. We don't actually hold those records on servers. Now, we do have some contract health records that we maintain the data of. I don't know NHS's remote hosting agreement with their EHR, so I can't speak to that, but I can find that out for you.
I'd appreciate that. Thank you. Okay, any other questions? Okay, is there, any new business, any announcements? Oh, I was going to ask, excuse me,
Wayne?
Secretary Hoskins, would you like to just tell us about the final beam ceremony? Or I know this is catching you off guard, but would you like to share that?
Oh, well, we had a wonderful ceremony to place the final beam on Hastings. I know some of you couldn't make it, and we understand, but we had a wonderful ceremony and well attended and very symbolic of where we are, because we are in fact ahead of schedule with construction, which is remarkable given the weather and other things we've had to deal with. So it's completely with the construction team and the health team. So
thank you.
If I could, Madam Chair, Cherokee Day is Wednesday, and we sent a hold the date, I think, in December to the council, but we also today, to the speaker just a short time ago, sent the agenda, same as in previous years, so you all are certainly encouraged to join us for the Cherokee Day in the Capitol beginning Wednesday.
Thank you. Thank you. Any other business?
Just a quick announcement, a follow-up with Councilor Buzzard. If any of you have constituents young constituents that are interested in the medical field, I've been helping young people for 30 years plus, so I help them with enrollment decisions, interview skills, learn to locate scholarships for them, so just feel free to give them my information if you come across, because we're always looking for Cherokees to enter the medical field. I have a hard time finding them, so be sure and give them my information.
I want to back that up, because he's good, because he worked with me when I was a student. I'm not trying to date you.
See, as Mike said, as Councilor Dobbins said, all his life he's pretty much been doing this.
Is
so
this our final product here?
That's it.
Okay, will anybody make a motion to adjourn? Motion made, second.